Welcome, everybody. Good evening. Bonsoir, tout le monde. My name is Ingrid Gingras. I'm the Director of Marketing at the Ottawa Hospital Foundation. Mon nom est Ingrid Gingras. Je suis directrice du marketing à la Fondation de l'Hôpital d'Ottawa et je vous accueille ce soir parmi nous pour une soirée vraiment spéciale. Welcome to the Ottawa Hospital Let's Talk Parkinson's event. Once again, we have a fantastic program lined up for you tonight. You'll know that if you're a returning guest, these four individuals in the front who are just itching to get up on the stage are definitely going to wow you with everything that they have to share. There are four of our physicians and researchers who are literally on the front lines of this disease. They've graciously provided their time tonight to give us the most up-to-date information, the latest exciting developments in the world of Parkinson's treatments. Notre programme ce soir mettra en valeur la compassion que nos scientifiques et médecins ressentent envers leurs patients. Ils partageront avec vous leurs projets, leurs exploits et leurs découvertes en ce qui concerne la maladie. Par la suite, ils répondront aux questions de la salle. Si vous n'avez pas la chance de poser votre question pendant le programme, ils seront aussi à votre disposition une fois le programme terminé. Le recrutement de nos scientifiques et médecins et les avancements en recherche qu'ils partageront avec vous ce soir sont seulement possibles grâce à la communauté et à l'appui de cette communauté et l'investissement de nos donateurs. Dans certains cas, un don peut être amplifié de 4 à 10 fois la somme initiale grâce aux revenus externes. Alors, chaque don joue un rôle important et nous en sommes très reconnaissants. April is Parkinson's Awareness Month, and so it seems very fitting that we're all gathered here tonight. And new this year, because this event has had such great interest both this year's and years past, is that we want to say hello to everyone watching via our webcast tonight. So I'm going to wave, and I'm expecting them to wave back, maybe in a very awkward way in their living room or their kitchen or wherever they may be. That's the beauty of this technology tonight. It's wonderful to have everybody tuning in and listening in. We know there's going to be plenty of questions for our panel members, and know if you don't get a chance to ask it during our program, they will be available later on tonight. After the Q&A portion, or right before the Q&A portion, we'll share for those on the webcast an email address where you can send your questions so that everybody can be very interactive. So to get things started, I'd like to invite my colleague Margot Lefebvre, Manager of Philanthropy at the Ottawa Hospital Foundation, to come and say a few words.
Thank you, Ingrid, and welcome everyone. As Ingrid said, it's wonderful to see so many people here with us tonight, despite the weather, and even more watching from home. So we thank you all for coming out and being with us tonight. One of the things we love to do at the Foundation is to showcase the incredible talent and expertise of our medical team at the Ottawa Hospital and at the university. It's a source of great pride for all of us at the Ottawa Hospital Foundation to be able to share with our community and with our donors that we have such incredible talent in the field of Parkinson's research, right here at the Ottawa Hospital. We are proud of our research talent here in our city, and especially with our team of Parkinson's researchers. It's a team who are dedicated, compassionate, and driven to do everything they can to help their patients. Great things are happening at the Ottawa Hospital, and in large part, this is because of strong community support. Many of you here tonight are already generous donors, and for that, we thank you. Your philanthropy is providing critical base funding for our scientists. And if you're just getting to know our hospital and our foundation, we encourage you to get involved and to support our researchers. And I would like to share a little bit about a group who does just that, named Piper, Partners Investing in Parkinson's Research. Piper is a small grassroots organization or group of individuals, all with someone in their life with Parkinson's. Piper is in its 11th year of raising funds for Ottawa-based research through Ottawa Race Weekend, and they have contributed an impressive $1.3 million throughout their incredible history. In 2016, Piper was recognized by the Association of Fundraising Professionals as the Outstanding Philanthropic Group of the Year for their incredible commitment to raising funds for research. The following video was shared the night they received their award, celebrating their history and the impact of the community support that they provide.
Good evening, everyone. My name is Sharon Martin, and I am the Senior Director of Philanthropy at the Ottawa Hospital Foundation. Thanks so much to the team at GoodWorks for supporting this award for Outstanding Philanthropists of 2016. I'm so pleased to be standing in front of this beautiful donor wall at the Neurology Clinic at the Civic Campus, for what better place could there be to honor partners investing in Parkinson's research for their significant achievements and impact. Piper was formed in 2009 by a group of investment advisors whose loved ones had been diagnosed recently with Parkinson's or who had been living with Parkinson's. They set an ambitious goal to raise $500,000 for research at the Ottawa Hospital through the Ottawa Race Weekend. Within 3 years, they surpassed that goal and they raised their target to $1 million. And as you can see, they had no problem in achieving that milestone. As a matter of fact, they did that in 2015 and they're still going strong. From a small group of 8 to 10, Piper Volunteer Committee has grown to 20, and that number expands to 100 with family members and friends joining them on race weekend. You can see and feel the energy and the commitment, and you actually visibly see the sea of red Piper shirts gathering at the start line. It's generations of family members walking side by side. It's our docs and researchers running with their families, and it's a daughter running in her first half marathon in honor of her mum. And the very next morning, Team Piper is out on Island Park Drive setting up the water stand to support and cheer on our half marathon runners, because that's part of the Piper tradition of giving back to our community. Truly, there are as many inspiring stories as there are Piper members. Our CEO, Dr. Jack Hitz, has said that the community does not follow, it leads. Piper, you have raised the profile of Parkinson's disease and the high caliber of research being done here in Ottawa. You have helped attract new medical talent. You have invigorated our researchers and helped fund the work in their lab and in the clinic. Truly, for a disease that immobilizes, the men and women and families of Piper continue to move mountains. You inspire us all. Congratulations.
So as I hope you can tell, Piper is a lively, passionate, and positive group with a firm resolve that they are not going to let Parkinson's rob them of their enjoyment of life. And while Piper's main focus is raising funds for Parkinson's research, it doesn't stop there. Piper Fit is an exercise component of Piper, developed in partnership with the Dovercourt Recreation Centre. Piper Fit offers 3 weekly affordable classes for strength training, flexibility training, and aquatic exercises designed for those with Parkinson's, and caregivers are also welcome to join. This year, Piper Fit is expanding to include classes offered at NeuroGym, a facility specifically designed to support the neurological community. And we have a new program coming soon called Piper Cares, which will aim to support caregivers and care partners of people with Parkinson's. Piper co-chairs Kim Teron and Roberta Driscoll feel that they have valuable information to share from their collective 30-plus years of supporting their husbands. Piper Cares will be a safe and open environment where a small group of people can gather privately to ask questions and share knowledge. We also have a number of experts who are going to join the group from time to time to share their knowledge on topics such as accessibility, managing medications, and dealing with the emotional side of this disease. If you would like to learn more about any of our Piper initiatives or consider joining us at Race Weekend this year at the end of May, please feel free to chat with Piper co-chair Kim Teron, Piper co-captains Shelby Hayter or Karen Fuller, or myself at the end of the program tonight. Thanks to strong community support, the Ottawa Hospital reputation continues to rise in many areas of research, and neuroscience being one of them. We are punching far above our weight. When you donate to research, your investment has the potential to find cures. But as much as we are excited about what lies ahead, we are seeing the impact of research in real terms today, in novel treatments that improve patients' lives. And of course, that is why we're all here tonight. We are going to hear from 4 leaders in Parkinson's research and care: Dr. David Grimes, Dr. Stephanie Bennett, Dr. Tiago Mestre, and Dr. Adam Sachs. So without further ado, I will pass it over to Dr. Grimes.
So I too would like to welcome everyone and thank everyone for coming out, and I guess our winter still does not want to let go. So I'm just in the next 8 minutes going to give you a very brief overview of where some of the, I think, the new treatments that we are hoping to get to the Canadian market are going to be in different aspects of treating Parkinson's. And then just a few minutes on just where we are with some of our clinical research programs. So one of the things I've been involved in over the last couple of years now is there is going to be the new Canadian guidelines for treating Parkinson's. They're going to come out in the Canadian Medical Association Journal, I'm hoping in the next 2 months. We're finishing up the final reviews, but it will be coming. And in the next couple of minutes, I just want to talk briefly about some of the new treatment options that are coming. And so you're all aware that there are many medications that we have available right now to treat Parkinson's. But the primary medication that everyone really with Parkinson's winds up on is Levodopa. And the problem is that although it works extremely well at the start, its efficacy does start to wane over time. And one of the big things that a lot of people struggle with is these fluctuations. And so the medication works for a few hours, or sometimes for some people even as short as 90 minutes, and then it wears off again. And you get into these more and more complicated schedules that we spend more and more time trying to manage. But as the disease progresses, certainly there's many avenues and many symptoms that Levodopa, although the mainstay, still doesn't treat well enough. And again, we always have to watch out for side effects, and so we're always trying to balance the improvement of making people move better with the risk of causing side effects like hallucinations. So this is a big area that's been involved in Parkinson's, again, for many, many years. And so there are a number of medications that have become available in other countries around the world, and we're thinking might be able to come to the Canadian market sometime soon. So there's this one called Opicapone, which is similar to a couple of the medications we have on the market here called Entacapone. Rytary is one that we've been involved in clinical studies here for many years, and we've been hoping that it's going to come to the Canadian market, but it's still not here. It's been available in the States for a few years. And another one called Sulfinamide, which is another medication that's very similar to Rasagiline, which I think many people may be taking already. These are medications that unfortunately are not breakthrough medications and are a little bit kind of Me Too medications, but I think it shows that there is activity in the area, and pharmaceutical industry is definitely moving towards trying to come out with better treatments. One of the things that some of you are aware of is the idea of trying to give Levodopa by an infusion. And so this idea that, I mean, you could potentially crush up your tablets, put it in water, and then drink it every hour, but really not very practical. And so there is this Duodopa therapy where it comes, you condense it down into a gel form, and then you infuse it. The big problem is you have to put it in through the stomach, and it requires a surgery to do that. But there is a medication that is being developed and is going to enter in and is entering into clinical studies, and this may be one of the ones that we participate in further down this year. This called where you're giving Levodopa actually just under the skin. So it's an infusion that just sort of comes under the skin. So less invasive, but again, idea of trying to help these motor fluctuations. One of the new areas for treatment options is what are called rescue treatments. And so people who have these fluctuations, they can occur very unpredictably, and you're not sure when the next event may happen where all of a sudden you're not able to move, and this idea of giving an injection. And so there is, the first one out of the Canadian market is called apomorphine. It has nothing to do with morphine, but is a medication that can flip people from being off to on in about 10 minutes. And it lasts only for about an hour and a half. So it really is to kind of a stopgap to get you back going again. Most people are not that excited about getting an injection, and so they have developed a way of giving it the same medication under your tongue. And so it's a sublingual formulation of apomorphine. And so we're thinking that may be coming to the Canadian market later this year or early next year. And we too have been involved in inhaled levodopa. So this is a puffer that you take, and the idea is, again, when you get into a sudden off, that it works within about 10 minutes. It doesn't seem to be as potent as the apomorphine solutions, but again, it's a medication that we think may be coming to the Canadian market sometime in the next year or two. So to develop these new therapies, to get them to market, requires a massive effort on everyone's part. And so here in Ottawa, we do have a very large clinical trials research program that some of you have participated in. So I've listed out, it looks like it's a very busy slide, but sort of lifted out the different, some of the studies that we're doing right now. So progressive supranuclear palsy is one of those sort of cousins of Parkinson's disease. But the idea behind this particular study is looking at trying to kind of pull out the abnormal protein. So it's a different protein in people with PSP compared to Parkinson's, but that sort of thought process of trying to suck proteins out is something that also is being applied for people with Parkinson's. We are doing a study looking at a new compound trying to improve memory for people who are having troubles with their Parkinson's and it causing memory troubles. There's a medication that has been in studies now for a few years. It's a medication that works on calcium, which is a common molecule that runs through our bodies, but it's also, this particular compound was originally designed to help your blood pressure, and there's been some studies that suggest it might be a way of slowing down the progression of Parkinson's. We're doing a very large study looking at a new way of trying to treat depression, not with drugs, but by psychotherapy treatment. And so this is a very large sponsored study from the Canadian Institutes of Health Research. We were fortunate enough for the Canadian guidelines to get a clinical grant money from Parkinson Canada, and they really have been the main drivers of helping us move this project forward. And as I mentioned earlier, it is coming to hopefully publication soon. A few other things. So one of the exciting new studies that we're doing is the ability to subtype Parkinson's. And so looking at genetic subtypes of Parkinson's and using that knowledge to develop novel compounds that interfere with that very specific pathway that affect people with a very certain subtype of Parkinson's. And so this is what's called the Lysosome. And so it's one of the things that your cell uses to clear out abnormal proteins, and we're hoping this compound is going to have an effect on making these protein clearing parts of your cell work better. Our integrated Parkinson care, Dr. Mistre, my colleague, is going to talk about that. We're also involved in a Canadian Parkinson Network grant. So this is going to be a cross-Canada study that's going to start up towards the end of the summer into the fall that I think many of you are actually going to wind up participating in. And it really is trying to collect more detailed clinical and blood samples from people with the idea of can we subtype and use that knowledge to better understand Parkinson's. I think, again, a lot of interest in cannabis and Parkinson's, and despite there being a lot of discussion about it, there's not a lot of science behind it in people with Parkinson's, but we're going to look at that towards the end of the summer in people with Parkinson's and pain, which is really the main area that cannabis has been shown to be helpful. We've been doing some studies, MRI scan, and you're trying to use an MRI scanner to help better diagnose and better understand Parkinson's. We've just finished a drooling study where a compound to try to help with the excessive drooling that a lot of people with Parkinson's have. And so I think you can see that there's a lot of activity in trying to come up with better treatment options right now. But again, we don't understand all of what causes Parkinson's. I've been showing this slide for many years now. And again, I use it because it looks complicated, and the bottom line, it is complicated. And I think that we are, though, figuring out the small details of these very complicated pathways better and better every year. And understanding those small details really makes it much easier to come up with ways to better treat it. So do we have any hope for really coming up with treatments that will affect progression and really big new treatments that will affect our ability to treat it better? And I think the answer is clearly yes. I was at a meeting 2 weeks ago that's a combined meeting looking at Alzheimer's and Parkinson's, and again, this idea of sharing information. And so we're definitely coming up with better targeted therapies. So synuclein's the abnormal protein that accumulates in the brains of people with Parkinson's, and we're able now to start to be able to manipulate that, and there's definitely clinical studies starting up with that. The idea of having, and the brain's very good at preventing things to get into the brain. And so that's been a big problem in the drug development market of coming up with treatments that will have a compound that actually gets into your brain. And so this technology and these molecules are definitely being rapidly, this technology is rapidly moving forward. As I mentioned, the idea of trying to use specific genetic subtypes and address and come up with therapies, and so we're already doing this. If you look at sort of global drug discovery, every year the technology and the mechanism to come up with better compounds is rapidly expanding. And one of the very exciting things at this particular study, at this particular meeting, was the idea of collaboration. And so I think you've seen within our group here in Ottawa that we have a very strong collaborative group. But the idea that industry is working with academia, that's working with government, that's also working with patient groups, it is coming together in a much more cohesive way. And certainly everyone getting on the same page is going to make things move much faster. Again, Parkinson's is not obviously the only neurologic disease out there, but the scientists and clinicians taking what we've learned in other fields of neurology is something that's rapidly getting spread across to many different fields. We definitely struggle with the idea of how do we measure Parkinson's progression? How do we measure if we've started a new treatment? Are we going in the right direction? And this is the idea of biomarkers. And we're trying to come up with better ways to come up with these biomarkers, and we are making improvements at that. And then we've struggled for a long time about how do we measure change in the clinic. When somebody comes in, most of you get really tired and get annoyed when we start doing these rapid hand movements. And those are really what we've been able to do from a clinical study design is, how much do your hand movements get better? But obviously, there must be much better ways and more objective ways to do that, and that is coming. And so this idea of using watches, Fitbits to measure movement, apps on your phone, and these kinds of things are coming into our clinical trials, and again, hopefully giving us much better data. So I know that's a very rapid overview, but I'll stop there, and we'll have time for lots of questions at the end.
Hi all, thanks so much for coming. My name's Steph Bennett. I'm a basic researcher and scientist at the Ottawa Hospital Research Institute, and I'm here to tell you about biomarkers and about another way of looking at how what changes over the course of disease can inform you about not only what's happening, but also inform you on how well treatment is actually working. So you all know that Alzheimer's disease, shown with the tau and the beta amyloid deposits, and Parkinson's disease, also dementia with Lewy bodies, is characterized by two primary protein hallmarks: the aggregation of aberrantly cleaved beta amyloid into plaques in Alzheimer's disease, the aggregation of fibrillized tau into neurofibrillary tangles in your neurons, and of course the deposition of alpha-synuclein in neurons as these aggregates. But what we don't often think about is that aberrant lipid metabolism. Now, most of us think about lipids as cholesterol, good and bad cholesterol, but they are so much more. That aberrant lipid metabolism is linked to risk of progression in Parkinson's disease, is linked to the risk of cognitive decline. And specifically, what is so awesome is that we all have these pathological hallmarks that are the incipient, deep-seated issues of the disease decades before you show any sign of Parkinson's disease. So what is it? Why is this long latency existing? And what could we do to identify persons at risk of Parkinson's disease before they even develop Parkinson's disease, at risk of cognitive decline in Parkinson's disease, and track them over time, and then stratify patients into these different subtypes by which we can actually properly address the issues of treatment with the right people at the right time. So what is truly amazing is that your lipid metabolism changes at the onset of when you actually see disease. So is this actually required for you to progress from a preclinical, prodromal, absolutely nothing wrong state to a state where you are starting to show clinical symptoms? And this we call the lipogenetics of neurodegenerative dementia. What does that mean? Very simply, it means that there are the genetic risk factors that are the highest risk factors for Parkinson's disease, its related dementia with Lewy bodies, and Alzheimer's disease, are not just those genes that code for the proteins that cause the pathological hallmarks, but code for lipid regulatory enzymes, meaning that your metabolism might dictate your risk or resilience. And these are some of the genes involved. Now, why should you care? Because we can change our stars. We consider genetics to be DNA goes to RNA goes to protein, that they're coded, the mutations are coded and deep-seated in you and then will emerge over time. But there's one other thing that's involved in the diseases that we are facing, and those are lipids. Because what are we? We are nothing but oil and water. Our brain cells, shown here as a representation of some of the lipidomic work I'm going to show really quickly, our neurons are made up of a beautiful shell of lipids, of which on the outside and the inside is water. So this raincoat, this shell that is what makes you think, is of something that is not coded by your DNA. Rather, it's made up simply of what you eat. I'll show you this in a second. Meaning that your lipids are assembled by enzymes that are coded in your genetics, but you can change your stars. You can change your composition of what your brain cells are made of through how you provide those cells with the lipids that make them up. Let me just really quickly show you. Here is thought. Here is neurotransmission. Here is movement. We're seeing neurotransmitters leaving the axon and engaging a receptor on the other side of your neuron. That's thought, and it's happening incredibly dynamically. You can see the neurotransmitter moving. And what is it that it's binding to? Your membranes are made up of these. We commonly perceive them as little squiggles, but what they actually are individual lipids, each of which has an individual shape and structure. And each of those come from diet and are reassembled by your enzymes to make up what it is your neurons are. And they look like this, and they're really simple. They're coded from carbon, they're concatenated. They're built up from carbon, hydrogen, nitrogen, oxygen, phosphorus, sulfur. Yeah, all real chemicals. But here we go, all atoms. But you can change those by what your diet is. Now, what is that going to tell us about Parkinson's disease? How is this going to make a better biomarker? How is this going to affect change and give your physicians the arsenal they need to say, oh, look, you are a special subtype of Parkinson's. You might require a different type of treatment, or you might be able to be tracked in a different way. Biomarkers. So each of these little spots that you're seeing, each of these colors, are an individual lipid. And here we're showing simply plasma, so what is floating in your circulation. And yellow means that it's increased, and blue means that it's decreased. And I'm showing you here Alzheimer's disease and dementia with Lewy bodies. Dementia with Lewy bodies is very similar profile to Parkinson's disease. And if you can see where the big red box highlighted, you can really see that Alzheimer's disease has a different profile in the circulation than dementia with Lewy bodies. So we are beginning to be able to stratify patients as to whether or not they are more Alzheimer's-like or more Parkinson's-like. But what does it tell you, and why should you care? Okay, look at the dots. It's awesome. These are floating lipids in your circulation. They're simply indicative of what your body is metabolizing and what is happening to you. In the top panel, you see there's lots and lots of red, which means an increase in these particular lipid species. I've given them numbers, but there's an increase in circulation. And these are a concatenation of averages of probably many of, possibly some of you who have given blood to the biomarker study that's going on at the University of Ottawa right now to see if we can tell differences between patients. So in Alzheimer's disease, there is an increase in these lipids, and these are pro-inflammatory lipids. What does it mean? It means that These folks are undergoing systemic inflammation. It's completely different than, as you see, the dementia with Lewy bodies, which is also very similar to the Parkinson's patients that we're seeing. You can see more blue, which means there's a decrease in lipid species. What does that mean? These folks are going through a resolving period, an anti-inflammatory period in their bloodstream. So we can potentially, and this is now moving, we have a larger clinical, I'm involved in a larger clinical study to validate these as possible biomarkers. We can possibly tell what is happening systemically by looking at your lipid profile in your blood, which is dictating possibly what is happening in your brain with respect to the lipid metabolism that might be predisposing you to progress more rapidly or more slowly with different disease phenotypes, and thus stratify patients. So, to conclude, the fatty brain, are we what we eat? So not all the mysteries of life lie in our genetic code. Some of these can be found in the beautiful shells of fat that sculpt our neurons and make us who and what we are and how we think. And these lipids can shape-shift at will, and they have the power to take over any number of forms such that they dictate whether your neurons can transmit or whether they are static, whether you're undergoing an inflammatory response or you're undergoing an anti-inflammatory response. And we believe, genetically and with the work that is being done by us and others, that risk of Parkinson's disease is associated with aberrant brain lipid metabolism that can be read out in your circulation, in your plasma. And diet can then change the lipid species that are present in these profiles. I'm not saying diet can alter prognosis, but it can change what is available to your body to create these species, some of which are toxic and some of which are not. And they can also be used to address how your disease is progressing over time using these biomarkers. So we hope to use these to follow the effective treatment, and as Dr. Grimes mentioned, there's the GBA study. We are one of the groups who are profiling the lipids following treatment with the lysosome inhibitors. And using these biomarkers to see whether or not there is improvement in the primary defect over time, and thus see whether or not that helps cognition. So thanks a lot.
Good evening, everyone. So really a wonderful voyage into the intricacies of the brain. And now I have to apologize because we're going to switch gears to kind of the other spectrum of, I guess, Parkinson's disease research, and looking at the effort that our research group has been developing in terms of how can we optimize today, now, the care of our patients with Parkinson's disease. And so this is a project that many of you have already contacted with, so the Integrated Parkinson's Care Network. And so I'll start with a brief review of why and what motivated us to start this process. First, because Parkinson's disease is a complex disease, so it's not merely a motor disease, not in itself as a motor disease already complex, but then has all these aspects that clearly we as movement disorder specialists many times were even not trained to address. So we can think about sleep disorders, sensory symptoms, dysautonomia that many times evokes the need, for example, for a gastroenterologist, a urologist, but also neuropsychiatric symptoms. So how are we able to address this complexity that requires these medical specialties, physiotherapists, nutritionists, and other allied healthcare professionals? And so these kind of questions, and also thinking about how can we empower more patients to manage their own lives with Parkinson's disease, how can we make this better? And also recognizing that actually in Canada, in Ontario, we are very fortunate to have in our health system already these different resources, but we have to recognize that many times they are just in different silos that do not communicate. And so that's kind of idea of breaking silos in our old health system. And then also, because we are in the 21st century, how can you bring technology that all of us thinks has a huge potential, and we can see it in our daily lives, but how can we bring it to the care in Parkinson's disease? So we started this idea of an integrated care network for Parkinson's disease, in which we try to bring the most of all the resources that can be potentially used by patients with Parkinson's disease and care partners, and try to optimize their use within the Ottawa region. And so, building this network of existing healthcare resources, bringing to the hub of this process a clinical care integrator, which is Diane Coté. She's just sitting there and really has been a huge driver of all these projects. Then try to bring health technology made for patients and inspired by patients. We'll speak a little bit more about later in my presentation. And then, very important, how can we make this a sustainable project and care delivery model from a cost perspective? Because we all know in our field that in some centers, the model of a multidisciplinary care clinic, it's a reality, but we also know, even by an experience in Ontario, that requires an enormous amount of funds, and many times it's not sustainable, as was the case in Ontario. And so this history perhaps started, I guess, 4 or 5 years ago, so almost my entire time in Ottawa. And so we first started by an initial pilot that actually we've presented in the past, and that already allowed to create preliminary data that actually made the funding of this project I'm going to speak about a reality. So this project, which was a more formal study of the IPCN, so involved 75 advanced Parkinson's disease patients, 25 newly diagnosed patients, so in a total of 100. And basically, we're comparing how these people with Parkinson's disease and their care partners were before experiencing this program, and this was a 6-month program, and how were they 6 months after. And so we wanted to see, is it possible to use this care network, this idea of integrated care in Ottawa? Also try to see what is the impact in the care, in the satisfaction of patients and care partners. Also have a notion of how much does it will cost. And ultimately, we want to have a version 2 of the IPCN that we can only also develop more in research, but actually can be a more efficient care delivery model for all the Parkinson's community. And I have to emphasize that this was a multidisciplinary and collaborative project. So not only involved mainly in our research group, myself and Dr. Grimes, but also from Bruyere, colleagues that had very good expertise in this notion of self-management support. So briefly, empowering patients and care partners to manage their own disease, the Parkinson's disease. And also from a more research methodology perspective, I think in Ottawa we're very fortunate to have the Ottawa's Medical Center that really provide key methodology support to do this study and ultimately to analyze the data that we collected. So I have to say this is the world premiere of the results of this study. So really no one else knows about the study. And so I'm very happy to be able to share it today. And okay, so let's go back. So I think this first slide first alludes to the success I think it was in terms of getting patients and care partners involved in the study. So usually, just for you to see, so we basically had 100 participants roughly after 6 months of active enrollment. So just for you to have a comparison, so many of the clinical trials that Dr. Grimes mentioned, usually we might recruit 5 patients in this period of time. So this study is certainly different from this type of clinical trials, but really showed the will of patients and care partners to take part in the study. So it was really a concept that I think is attractive to the Parkinson's community. Then looking at patient views on the experiencing of the IPCN, so after 6 months, I think the results are striking. So in terms of an holistic notion of improvement in living with Parkinson's disease, we do have that the majority had slight improvement or even much or very much improved. Curiously, if you look at satisfaction, and this is it's an important concept that many times it's really not assessed, especially in these kind of interventions, we see that the vast majority were satisfied or very satisfied with their experience. To what that reflects in terms of their quality of life, in terms of living with Parkinson's disease, I think it's a huge challenge that we still need to address better in future trials. And this kind of number that you see for that scale called PASIC basically illustrates how well patients, how well they experience the care that they are provided by the healthcare professional. So a positive number means that it's a better perspective on the care that's delivered to the patients. Then, looking at caregivers, and I think there's similar results. So overall, I think there was a very good impression of the program, both in terms of the description being the vast majority good, very good, or excellent, but also there's this aspect of satisfaction about the program after the 6 months. Then, other outcomes that usually, or measures that usually we are more familiar with. So we looked at quality of life using a Parkinson's disease-specific scale. And you might recollect that there's two groups. So advanced Parkinson's disease patients that we pragmatically define as having more than 8 years of disease, so usually have more of those problems that I presented in the initial slide. And so only on this group, there actually was a measure of improved quality of life. And this is, I think it's quite remarkable, because many of these studies done in Parkinson's disease, they even don't capture improvement in quality of life. But again, this is still an initial study. And then there was potentially a trend of a sign of less reduction in costs. I think needs further assessment. So main conclusions. I think the IPCN and I think our research group is quite happy for these. That was very well received by patients and care partners. I think there's improved perception of chronic care, improved health-related quality of life in advanced patients, and possibly it could have some benefit for societal costs. It's important to emphasize that this is not the end of this story. We are planning to do a larger trial in Ontario involving 4 sites for which we are seeking yet funding, but definitely these results, I think they're going to be fundamental, instrumental to be successful for the funding. So I think everyone in this room as a Parkinson's community should be quite proud to have been turned possible this study, and I think we'll have more fruits of success in the future. And these are some of the aspects that we are currently developing. So briefly, we are trying to develop the part of the technology that really was not included in the initial study. So our idea is to create this patient portal where patients and care partners can find information key for this empowerment and for the self-management of living with Parkinson's disease. But also, we wanted to see this to be something flexible, and for which you can have different modules of some of the things that, for example, Dr. Grimes mentioned, for example, a Fitbit, a Apple Watch, or other wearables devices in the future that we think could be beneficial for the care of patients with Parkinson's disease. In this particular development, we really have a priority of making this a project that is driven by patients and is for the patients. So we just concluded these participatory design workshops that actually gave us very important ideas, and these were both from patients, care partners, but also actually healthcare professionals, of how these tools should look like to be easy to use and ultimately have an impact in the lives of patients. And finally, I think it's a current project that we involve and really alludes to the need and how important this seed funding and these seed pilot projects are so important. So this is an international project for which Ottawa is the coordinator member and involves 6 other European countries. And basically we organize in a consortium trying to export and apply the ideas of the IPCN in these other European countries. So this is a 3-year project that we're just starting. And obviously we're quite proud that we've been able to successfully, hopefully in the future, to bring this concept to other parts of the world, and of course expanding it in Canada. And I think with this note of hope, I think it's the last slide of my presentation. I'll be happy to answer any questions at the end. Thank you.
Thank you once again, everybody, for being here, and thank you to the Ottawa Hospital Foundation for inviting me to speak. I was going to talk about what I think is the easiest subject of the night, which is the technical details of how to do deep brain stimulation surgery. And I was hoping to do it in a way that shares some of my philosophical thoughts on how surgery, how any surgery is done, and particularly how DBS surgery is different from other surgeries, and also in a way that motivates some of the research projects that we're engaging in my lab. Parkinson's disease is a network problem, is a network dysfunction, and that's the reason why deep brain stimulation is thought to function, because it's able to restore the imbalance that's on the B side that occurs in Parkinson's disease, and attempt to restore the circuitry of inhibition and excitation. The main goal in deep brain stimulation surgery is to implant an electrode in a specific area of the brain chronically, and to allow restoration of the function of that network. And it's the problem amounts to how do you get from the outside of the head and drive a 1.17 millimeter nail to a specific part of the brain. And to solve that problem, we convert the head into a 3-dimensional coordinate system, a mathematical coordinate system, and then use a combination of imaging, navigation, and physiological investigation to try to determine exactly where that target is. Now, this was in terms of a technical detail. This is classically done with a frame, and this is the way that a lot of centers do deep brain stimulation surgery. Again, the goal is to get the electrode in the right place. As a technical note, one more thing. There are a number of patients' images and movies that I'll be showing tonight. Everybody that is in this presentation has consented to have their images used. Nevertheless, I've taken a very rudimentary attempt to anonymize some of the patients who are in this. I don't use a frame. I use a newer method which allows frameless stereotaxy, but the trade-off is in clinic the day before, I have to implant little screws in the head. I've done both frame placement and frameless, and I believe that the placement of fiducials under local anesthetic is less invasive for a patient than a frame. And I know that there are a few people who have had deep brain stimulation, both with frame-based and frameless technique. And if there are any such people in the audience, I would encourage you to come and find me, because I'd be interested in your experience. So in the operating room, there's no frame. The participant, the patient, lies, and the C-arm, this is normally used for an X-ray. I use it as a $200,000 drape holder. to convert the operating room into one half, which is the surgical space, and the other half, which is the patient examination space. And the frameless technique has been validated in the literature. So first we use an MRI, we find the target, and we target the MRI. But how do you get from an MRI to the patient's brain? So that's where the fiducials come in, and that's the concept of neuronavigation. So do a CT scan and an MRI, co-register the images, and because we have these fiducials, I label the center of the fiducials in the image space, and then in the head space, we do a co-registration. So we have a navigation system that is optically based, and we have optical spheres, and then I input where those markers are. So the computer knows, okay, that's in its image space, where are we in the patient's brain? So that gets us pretty close, and we use that as an entry point. Hopefully none of you are bothered by surgical images. I don't think they get too bad in the so then we build from there, so everything gets secured into the skull temporarily. So we build up this temporary tower to drive into the brain. We re-register, by the way, once everything is secured into the skull for the target, because we want to be within a millimeter or so of the target, and then use the recordings to get to that. So this is the next frame. It has 2 degrees of freedom, and those degrees are rotate and sweep, which are shown. Oh, and while that's happening, I have a video game that appears on the navigation system, and so my job is to center the aiming reticle and the aim point. So I encourage my own children, and I would encourage you to encourage your children to play video games as much as possible, because it translates to skills later on in life. So this is the way that the system aims. And then once we secure it in place, we can add on the micro drive. The micro drive allows the surgeon to advance within hundredths of a millimeter with microelectrodes to listen to the neurons. And we're going to listen to the neurons in this talk. One more thing, the goal is, when we listen, to make labels, and to use those labels to determine where we are in the nucleus. Now, the classic way of doing this is to look at an atlas like we have over here, where there's a slice on one person, and they've reconstructed where they believe the nuclei are, and we use this as the basis for our understanding of anatomy. Well, that makes no sense, because we know that everybody's brain is different. We know that everybody has a different MRI. And so one of the research projects that we're working on right now is to build a virtual reality model that's specific to each particular patient, and so that in surgery, I would don the virtual reality goggles, input all the physiological data onto the patient's own MRI, navigate inside the patient's virtual brain, and determine where to place the electrode in three dimensions rather than in 2 dimensions on somebody who's not even the patient, which is the current standard of care. So we do different passes with the microelectrode, find different neurons, and we're able to move it with the micro drive to where we need to be. Okay, so I want to give an example of that and show some recordings from a person's brain. I find this interesting because, as a surgeon in general, as we do as we open and do an exposure, we're constantly trying to estimate what the anatomy is. So we get a few landmarks, and we visually, typically, update our own internal model of what the anatomic landmarks are. And I think that this is probably the only operation where we're not using vision, but we're using sound. We're using the hearing system, the auditory system. In fact, I think it's better because you can hear different frequencies better. The discrimination of the auditory system is better than that of the visual system. And I hope that I can convince you of that. So this is a target, the GPI, and there are a number of structures that we encounter on the way. The striatum has low amplitude spikes with low frequency. GPE, which is encountered, that's the blue one on your way down to the center, has 2 types of cells that have bursts and then long pauses, and cells that are constantly firing, then have these pauses within them called GPE pausers. Border cells are encountered between the nuclei and are very regular, and they're different because they're regular. GPI is loud, it's obvious, and has high frequency cells and a lot of what we call multi-unit, a lot of different popping sounds that we can't even discriminate. So I'll take you through that, and hopefully, let's see. Okay, that's striatum. That's the first one. So low amplitude, low frequency. Look at the blue tracing at the top. We often listen to multiple simultaneously. Second level is GPE. So you can hear the sound. Those are the neurons, and you can hear the pattern, and that is. Those sounds allow the surgeon to know where we are in the brain and if we need to make any adjustments. Here's a border cell. It's very regular, it's very distinct, very different from GPE. And then we're in GPI. It's louder, the background is higher, the amplitude of the action potentials is higher, high frequency. Here's another one. This is a multi-unit, so there's, again, the background is high, but there's, and then in this particular target, we actually go below the target into the optic tract and flash a light in the patient's eyes and listen for an increase in the sound. And so you can just hear, sounds like a wind on a beach. But you can hear a slight rise when the light shines in. There. So these are the things that we use to determine where we are. One of the other research projects that I'm working on is trying to put neurosurgeons out of business by automating all of this. So if a surgeon can listen and learn, then and I've done 60 or 70 cases in Ottawa, plus additional surgeons. There's rich data set of labeling of targets. We are, one of the projects we're working on is trying to use machine learning to automatically label the targets. And perhaps instead of having a microelectrode with one that can record on one tip, having a microelectrode with, say, 30 contacts within a centimeter, that we could just advance right away, save hours of time in the operating room, and improve the accuracy by using machine learning to determine where the various structures are. So the stimulator is ultimately placed, and then we do test stimulation. So we don't always, and this talk I didn't want to talk about outcomes. There are 5 randomized controlled trials that I'm aware of demonstrating the efficacy of deep brain stimulation in well-selected patients. But sometimes we do get clinical benefit in the operating room. I want to show a couple of examples of that. So this is a patient is trying to do alternating fist and finger extension before the surgery. Oh, my attempt at any rate, as I mentioned, every patient that is in this talk has given consent to have their images and videos used both verbally and in writing. The last minute transfer to the PC did not result in the best automating. So this is the same. This is much of the same, showing that that the rapid movements become a little bit faster once he gets to alternating fist and finger extension. Well, let's see if the next slide does any better. So this is a patient with a tremor predominant Parkinson's disease, and the lead is in place. So we stimulate it, and you can see immediate improvement in the tremor. And then it's too bad because it's too bad that I blocked out his face because we turned off the stimulation without telling the patient, and you could see his smile kind of go away as his tremor starts to come back after we turned off the stimulation. So it starts with the finger tremor, and then there we see it just start. So the washout was very quick in this nucleus, in the STN. The stimulator is off. So one thing that I should mention is that the electrical field is proportional to the voltage and the current that's applied, and this brings to mind that side effects can occur when adjacent structures are inadvertently stimulated. And the STN is in a dangerous neighborhood. So if we're a little bit lateral and we get internal capsule, we have involuntary muscle contractions, anywhere else within the red nucleus, we might get problems with eye movements or with double vision. And a little bit too deep, and we could get increase in akinesia or depression. So the accuracy of placement is not just to maximize the benefit, but also to try to navigate this difficult and crowded neighborhood of neurologic structures. So in conclusion, DBS is well established for the treatment of movement disorders such as Parkinson's disease. The frameless techniques allows for what we believe is a more comfortable patient experience with equal accuracy. And accurate placement is essential for the best effect of DBS with minimal stimulation side effects. Deep brain stimulation in Parkinson's results in the best results for tremor, rigidity, bradykinesia, and quality of life. Thank you.
Oh, you guys beat me to it. I was going to say go take a seat. Okay, it's time for our Q&A portion of the night. I'm sure you've all been sitting there thinking about what you would love to ask our panelists. What I am taking home from the last presentation is my children need to listen more and play video games. I'm not sure if that's the same thing you all took home. And I also wanted to let you know what Dr. Sachs mentioned today regarding virtual reality and deep brain stimulation. In a few days, once we've organized ourselves after this event, we're going to be sending you an email that includes a video featuring Dr. Sachs that the foundation worked on that explains that virtual reality a little bit more. And please enjoy once we get it. So the way the moderation here is going to go, I have two team members, Elena and Kristen, who are there ready to take your questions. And as mentioned earlier on in the program, we also have an email address for people watching from home, donorrelations@toh.ca. Vous pouvez aussi écrire vos questions en français, il n'y a aucun problème. And we're going to try to assign the most knowledgeable member of the panel to answer the questions from the crowd. So first one is always a little nerve-wracking, but we do have a question right over there, Kristen.
Hi, thanks very much. This is a question for Dr. Bennett. You were talking about diet. And I was wondering if you could expand on that a little bit more in terms of like what kind of diet would be good, bad, or indifferent. I don't, yeah.
Yeah, I get that question quite a bit, and it goes actually to what Dr. Sachs is saying. It's extremely individual. What I mean by that is that the overarching hypothesis is that there are critical changes in your metabolism that render you susceptible, vulnerable, or resistant to progression. So when you say what changes in diet are required, it's actually a tough one. It's what we're actually working on right now. What we've done in the studies that I was showing you is taken the wonderful cohorts who have come to us and randomized them throughout from communities across the world. So there isn't one diet that is in those studies. What we're trying to find is what are the changes that are common to people regardless of diet that would then need to be targeted. So when you ask me what are the dietary changes that would be beneficial, I would need your blood to have a sense of relative to where we think we're going, where your metabolism sits. And then, but what I can tell you is that in both a rat and a mouse model that we've just completed, for animals that, remember the lipids I showed you had shape? So every time there's a double bond in a lipid, it has a 30-degree kink, if I can do this, right? So every time there's a double bond, you go like this. There's no way I can do docosahexaenoic acid, which is in fish oil, especially in a skirt, because I'm going to have to do yoga, right? But if there was a subpopulation of mice, of a mouse model of Parkinson's disease with dementia with Lewy bodies, who were showing the anti-inflammatory, the resolving effect had basically dropped. So their immune systems, their capacity to respond to inflammation seems to be very, very, very low. When we supplemented their diet with lipids that had less double bonds, so tasty things in corn oil and soy, it delayed their progression. But I can't say that's good for you or you or you until we scan the blood. That's why we're looking for for biomarkers through the program that's going on now to be able to answer that question individually, and I'm hoping to do it one-on-one. I realize that was hand-waving, but it's one-on-one. Thank you.
Okay, we have a question that came in through our donor relations line. This one is for Dr. Grimes. Is there anything we can do as patients to advocate for some of the medication therapies available in the US but not in Canada?
Good question. I think, the squeaky wheel wins out oftentimes, and so Parkinson Canada has been a big proponent of trying to push for newer medications coming to market and trying to speak to the politicians to get that done. And so I think that is something that everyone can be involved in, is really advocating for trying to get new medications. And so it is something that certainly would play a big role in sort of pushing things forward and trying to get medications to Canada. I think big pharma, when we're a tenth the size of the US, it makes it, I think especially in the last 10 years, it makes it maybe, we're often sort of second fiddle just because of numbers games. But I think if something really is very effective, then we definitely need to push to get it here.
Any questions from the crowd? Any hands? Okay.
Hi. I'd like to know more about some of the symptom relief efforts that can be done in, I'm specifically talking about freezing and hearing that there's sort of an inhaler or something that would help with freezing, but more about the symptom relief, and is there more going on in terms of symptom relief that isn't perhaps the classic medication route?
I guess for freezing specifically, there's people who are looking at it from all different angles, whether it's various devices, lasers, music, all kinds of things to kind of reroute the brain circuitry to work better. I think from a medication standpoint, freezing is definitely has limitations, and so medication adjustments when people have on-period freezing often doesn't work. And for on-period freezing, even the deep brain stimulation is a therapy that may not work either. And so we really are, that's definitely one of the fields where we need better treatment options. And so some of the newer ones that I mentioned are ones that are still probably not going to help on-period freezing.
A question from our donor relations line, this one for Dr. Sachs. How long do the results, or I guess effects, from deep brain stimulation last?
So there's data demonstrating that beyond 10 years that it's still providing a benefit, and I think that's what we clinically see as well. Parkinson's disease is a progressive disease, but typically people continue to benefit from their deep brain stimulation. And in fact, one of the issues that often arises is when people have to get their batteries changed. Their disease may have progressed, and if their battery dies before we have the opportunity to change it, they may be sicker than they ever recalled being. And so people continue to benefit from deep brain stimulation, and we have to make sure that we are continuing to manage them and the systems because the downside, the flip side is also true. That they may get very sick with the loss of stimulation.
So 2 questions here. The gentleman second last row, he was a fraction of a second quicker than you, sir.
Thank you. The question for Dr. Grimes. You're referring to levodopa as a gold standard in terms of treatment of symptoms. Does it also offer a neuroprotective aspect to it?
So that's something that's definitely been debated for a long time. Is levodopa toxic? Is it levodopa protective? And I think the more studies that have come out, probably it's neutral. It doesn't have any long-term protective effect, but it also doesn't have any long-term negative effects. People have tried to look at it from many, many different angles, whether it's in the lab or within people. But I think the overall evidence is it really helps symptoms. I think when you look long term, so before we had levodopa, definitely people were not surviving. So the average lifespan of somebody with Parkinson's before we had any treatments was about 10 years. So now we're clearly doing much better. So from being able to get people moving better, we're definitely having. It's clearly beneficial, but I think in terms of having an underlying effect on the mechanism of the disease, we don't think so.
Okay, the gentleman right here next to you, Elena.
I'd like to return to the question of getting Canadian access to the new drugs. What's to prevent a Canadian from going to the States or Mexico and buying a 6-month supply and bringing it home?
Those border guys.
We said the Americans seem to be able to buy medications from Canadian companies and get them through the mail.
Yeah, so, I mean, certainly the whole sort of cross-border medication thing is being clamped down on, and so that's certainly one of it. But also who's going to provide the prescription and stuff. If I write a prescription for a medication that's only available in the States, it's actually not valid. So you'd have to see a physician down there. I guess you could potentially see a physician down there. Get the prescription, buy the medication, and then sneak it back across the border. But
if you go to Mexico, you can often get these medications without a prescription.
Again, it's probably a numbers game too. If you're trying to get back across the border with big boxes or big bags of pills, the border agents won't be so excited.
It's the Canadian border agents who would intervene, is it?
Yeah. And so, all the medications in Canada need a special number, and the Canadian government tracks that. So.
I'm going to Dr. Grimes. You're getting hammered here with drug questions tonight. This is great. Just a follow-up question for you from somebody who emailed us in. Again, looking about when advocating for drug availability, who should they reach out to? Are we talking here our counselors or politicians, right? Who can help us in this quest to maybe speed up the process?
I think with our Canadian politics starting local and trying to shake the tree, and so when they're in Parliament and they're having a vote on something that it might favor better access for drugs, that's certainly one of the ways to do it. Parkinson Canada, as I mentioned before, plays a big role in trying to advocate But again, it's definitely an uphill battle, and it's often actually not the Canadian government that's putting up roadblocks. It's pharma companies not marketing the drug. So it's not our own healthcare system that's often limiting it. It's the manufacturers saying, they're obviously in business to develop new treatments and bring them to the market, but also to make money, and so that they there's going to be a real, if they see it as a smaller market share, they may not be where they want to put their resources to get the drug going right off the bat.
Kristen?
So perhaps I would just add.
Oh, yeah, absolutely.
So I remember maybe it was like 3 or 4 years ago, I was in a congress in the US, so I asked actually the pharmaceutical company of Rytary, so when you're coming to Canada, and it's really what Dr. Grimes was illustrating, so they had just been approved in the US, to go to Europe, to the European Medicine Agency, and then potentially Canada. And I think from the Canadian perspective, that's also the aspect that the drug cover system depends on each province, instead of being the whole country, which from a political perspective definitely would make it more attractive.
Okay.
But that's more politics at the federal level, for sure.
Absolutely.
I mean, I've been involved in some of these things on the sort of approval side of drugs, and so it is definitely a very complicated process. I mean, you obviously, you want to access these drugs, but you need to make sure they're safe. And so the mechanisms in place to make sure that all the studies were done, all the basic science was done right, there's no sort of red flags, there might be something wrong with this new medication. And so it is a very complicated process. And so the pharma companies really do have to put a massive effort into submitting this all to kind of Health Canada, say, here's our new drug, and will you move it forward?
Okay.
To Dr. Sachs, and what you were saying about the deep brain, I'm over here.
Bright lights.
There's a bright light.
Yeah.
What you were saying about the deep brain stimulation, I gather you never turn it off. It's on all the time. And where does this battery, what makes it go?
So one thing that I didn't mention, I'm a surgeon that implants deep brain stimulation. I work on the program in partnership with Dr. Mestra. So we discuss patients beforehand to find the best patients, and then afterwards he does the programming and the adjustments of what frequency, what electrodes to use, pulse width, and things like that. And so it's tunneled to a pacemaker device, which we call an internal pulse generator. It actually looks like a pacemaker, and the batteries are the exact same batteries. They're made in the same facility. And I put it on the right side to leave the left side for the cardiac surgeons later on. So once they are programmed, the programming is typically continuous right now. This is an area of research because, of course, we know that the symptoms of Parkinson's disease are not stable. They fluctuate, and so this concept of closed loop stimulation is a matter of of interest to a lot of labs, including to our own, trying to look at what signals can be used to trigger something, for example, freezing or some other transient problem in Parkinson's disease, to change the programming to fit the problem that's being faced at that time. That doesn't exist right now, but it's something that is being investigated actively in a number of labs.
Okay.
The entire system is under the skin.
Thank you.
The leads go to a wire, the wire goes to the pulse generator, which is a pacemaker, all under the skin.
I'm going to go to a question online for Dr. Bennett here. One of our viewers is asking, is there a way you can get your blood tested to see what foods would help?
Yes. What is the Parkinson's group that I'm involved? I call it the Parkinson's Blood Bank, but
yeah. So some of you actually already donated blood, and so this is part of some of our biomarker research, where we have researchers who are looking at all kinds of different aspects, including this. So that's one of those things. I mentioned briefly this idea, this Parkinson this Canada network of, and this is one of the things that we're going to be doing. And so Dr. Bennett is going to be one of the researchers we hope is going to have access to when we get enough samples from people from across the country, we can start dissecting down some of the more details and trying to subdivide people. And that's going to, again, this idea of having sort of a repository for scientists to really try to dissect out and learn more things.
So I guess, so right now, they could get it tested, but really it's just helping to build the data. We're not quite sure yet what the data would mean. Is that?
It would help to build, especially on the folks that we're following longitudinally, it would help to see whether or not what the biomarker, validate the biomarker that is now, and whether or not there are changes over time, and also whether changing then in a second, whether changing diet changes that. I am involved in a clinical study right now, which just ended at Sunnybrook, wherein we were patients were supplemented with fatty acid vitamins, and that research has demonstrated a change in depression in the context of Parkinson's disease that we're working on publication right now, but it wasn't longitudinal enough to see whether or not there was a change in anything else. But absolutely, if we get involved in the, as we are involved in, if someone wishes to be involved in this, then absolutely.
Okay. I'll take one more question online. There's a few coming in, which is wonderful. Not sure who can answer this one, though, so listening ears. Are you doing any research into cortical-based degenerative disease, or do you have any advice?
Do you want to take that one?
Yeah. So the shorthand is that no, we're not doing on this very specific disorder, which kind of relates with one of the other disorders that actually Dr. Grimes mentioned, in which we're involved in a clinical trial, which is PSP. So both are rare compared with Parkinson's disease. They do, but in some way there's a little bit of a caveat, because the diagnosis of what I think was mentioned as cortical basal disease actually is post-mortem.
Yeah.
So actually, there's interesting studies showing that the vast majority of people that are diagnosed with that condition actually wind up having post-mortem PSP. So in that sense, I can say that some research that in living patients is on PSP could potentially translate to patients with CBD in the future, which that could be the cortical basal disease.
Okay.
And I think that highlights this idea that when we're learning something in one neurodegenerative disease, it may rapidly become applicable. So the things like this idea of things in Alzheimer's that they're learning and trying to pull out proteins, things in PSP, that we can flip them into other things like cortical basal degeneration. And so that there's definitely overlap. So even if I'm not specifically studying that particular rare subtype, it's still the things that we're learning in other diseases may be applicable.
Okay, we're going to take a few questions from the crowd. See, this is what happens, right? You were all shy to start, and now those hands are going up. So we have a lady right here. Then we're going to go to the gentleman at the very top, and then this gentleman here, and then I'm going to go back online. So please go ahead.
Thank you. Dr. Sachs, who would determine who's eligible for the deep brain stimulation?
So every patient that is referred to me is referred through Dr. Mestre. And then we have a team that assesses the patient to make sure that they fit the criteria of what we know to be the best responders to deep brain stimulation. And that includes psychiatrists to make sure any mood disorders have been optimized, a neuropsychologist, as well as Dr. Mestre does a levodopa challenge to see the change that occurs with levodopa, because one of the concepts in DBS is that response to levodopa predicts response to DBS. And one of the things that I tell people before surgery is that DBS will not get you beyond your best on medication. But what we hope to achieve is to stabilize that best and reduce the medication and the medication side effects at the same time.
And I have just one more question. Have there been any studies done regarding long-term use of either prescription drugs or the illegal drugs. Only because I have had 2 family members, a mother that was told she had drug-induced Parkinson's from so many antidepressants, sleeping pills, on, and then a brother who was also told that he's got the drug-induced Parkinson's because he was raised in the 60s, so there was a lot of heavy drug use back then. And I'm just wondering, has there ever been any studies done regarding the effects on Parkinson's?
So, I mean, yeah, I mean, there's certainly the sort of various, so toxins that you could expose yourself to, or directly or indirectly, have been looked at for a long time. There definitely are some famous studies from the 80s with a specific recreational drug that gave people Parkinson's overnight. Is probably the most dramatic example. But the chance that you're going to get MPTP is extremely rare. But I think that the general drug use, whether it's cocaine or these kind of heavier street drugs, the evidence that would lead to Parkinson's later in life, I'm not aware of any. No question that there are many drugs that potentially can block dopamine in your brain, though. So having drug-induced Parkinson's from taking a medication right now, that certainly is a possibility, and we see it quite commonly in the clinic.
Are you working with people with dual diagnosis, like somebody who is full-blown Parkinson's and bipolar, who's on a lot of bipolar medication?
Definitely, we see those people in the clinic, and definitely it's a bigger challenge to manage them when they're taking medications that have detrimental effects on their Parkinson's symptoms. So it's definitely a harder thing.
So we have about 9 minutes left. I want to remind everybody, and I'm hoping all 4 of you can stick around for a little bit afterwards so that our guests can ask more questions. So I'm going to ask you to keep your answers brief right now so that we can make sure that we address as many as possible from the crowd. Kristen, do you want to head up there to that gentleman right here who's been patiently waiting for his question at the very top, please? Thank you.
Dr. Grimes, and it has to do with freezing, and it has to do with the fact that I have been finding that if I do what I call deep breathing for a while, it seems to relieve the freezing. Is there anything in the literature, in your practice, that would say this is really happening?
As I mentioned earlier, there are lots and lots of sort of tricks that seem to overcome freezing. The unfortunate thing is they tend to be very short-lived. So I mentioned briefly the idea of singing, and I think that may be somewhat along the sides of sort of deep breathing. And so the idea that there are many different ways to temporarily overcome those freezing aspects, but we don't understand how that works very well. And I guess I'm not allowed to say more.
All right. This gentleman right over here.
Thanks. The breadth of research that you're involved in is impressive, but I suspect that not everybody, that you don't get to do all the research you would like to. So what would be the next thing you would tackle if resources were not an object?
Could I get each of you, actually, if you're comfortable, to answer briefly? That's a challenge with researchers, isn't it? Dr. Grimes, would you like to start? What would be next?
I think that there maybe not any easy answers. There definitely, there's many aspects of Parkinson's that we need better things. I mean, I think the opportunities that we have the potential opportunities to participate in clinical trials, and some of them we have to say no from just because we don't have enough time to take them all on, either ourselves or our research staff. So time is definitely a factor for us as one aspect.
If I had unlimited funding, I'd like to go straight for precision medicine. I'd like to find out what is the metabolism we are all undergoing now, and what is our level of pathology in our brain. So what makes you resistant and me vulnerable to progression, and not just with lipid metabolism, but with omic metabolism. So a full not just your genomics, but a full metabolomic profile of each and every one of us over time to be able to get at how you can change your stars. So.
I think I would head on the notion of time, but also of potentially expanding the infrastructure, and with that also, I guess, funding that allows to be able to work more in collaboration, in multidisciplinarity, and I guess if I have to pick a topic, it's so hard, but I think one that potentially could bring further impact in the disease, it's actually knowing more about the heterogeneity in Parkinson's disease. Why patients seem to have such different trajectories in their lives. And kind of Dr. Grimes mentioned a little bit about the genetics. We know that doesn't explain everything. So how are we able to actually, in the future, with a blood draw, identify a biomarker that actually links to a specific medication? And that's, I think, will be a tremendous breakthrough.
Well, I work in the relatively narrow space of deep brain stimulation, which the majority of people with Parkinson's disease would not benefit from. But I'm interested in this idea of the next generation of deep brain stimulation, which is personal to the specific problems that person is encountering at that time. And the way that I would go about that goal, if I had unlimited resources, would be to try to understand the networks better, because we right now understand the networks just from primate models, but even then from only single unit recordings. We don't really have a network representation. But if we want to disrupt the abnormal networks, we have to understand that better. So I would record with multiple channels throughout the brain, and try to understand the network behavior during things like gait freezing or dyskinesia or other specific problems that a person might be encountering at that time, so that we can make a closed loop system that reacts to those problems in real time.
So you heard from all of them. That's great. A question from our donor relations email. Is there a link between exercise and the rate of deterioration? Perhaps the question is, does more exercise lessen the speed of deterioration?
Yeah. So that's actually, I guess, a common idea or something that we commonly, question we address. And I guess ultimately depends on what we think about what's the definition of progression. But ultimately, I think what the studies show, and definitely are complex studies that to address really how exercise as intervention can be beneficial for Parkinson's disease, I think ultimately exercise is good, and that's what we kind of recommend to our patients. When we get into the details of what's the regimen that it's better, what's the duration, you really don't have a very good evidence-based recommendation. And so usually I tell to my patients, I think David does the same, just exercise is good wherever that you feel safe doing and pleases you and you have fun doing, that's highly recommended. And so in terms of disease progression, really the studies do not show an effect or impact in the progression of the disease, and because they might help with the symptoms while you're practicing the exercise, but if you were to imagine your clone that did not do any exercise, if you were the one doing exercise and then you stopped out of 6 months or 12 months and both were on the same regimen of medication, the evidence tells us that likely you'll be in the same functional status if the clone would stop doing the exercise.
Okay. Have we done any research on low-level laser therapy on humans with PD? And if so, is it effective? Anyone? A follow-up response, perhaps?
So I mean,
question?
I think they're starting from a surgical standpoint. They're looking at lasers and whether using a laser might be a way to sort of burn a hole in the brain. But I think that's not going to be a big breakthrough win. I think as you heard, it's all about trying to find the right target, but we know how to. There's many different ways to destroy that target or enhance that target. So I think, in my mind, lasers is probably not going to be a big win. I don't know.
There is a concept, a field of science called optogenetics, in which cells are bioengineered so that they express on their surface receptors that respond to light. It's been huge in animal research. But as one scales higher, there are significant bioengineering obstacles. And so I think that there's a lot that we can learn from optogenetics in terms of Parkinson's disease. But I'm not sure that I see in my career optogenetics being a therapy that we would deliver, with fiber optic, You can imagine instead of deep brain stimulation electrode implanting fiber optic. I'm not sure realistically I see that in the next 20 years.
Okay, I'm going to share one more question here that came into our inbox. There's still many to go through. Unfortunately, the folks at home or in the comfort of their living room, wherever they may be, won't have access to our docs for the next few minutes. So I think this one will resonate with a lot of you, a lot of questions that you've been asking. And what we'll do to the folks who have not had a chance to have their questions read, we'll be following up by email and hopefully provide you with the answer you were looking for. So the question here is essentially, what methods are you using to recruit research study participants? So if patients, family members are interested in finding out more about clinical trials and research projects going on at the hospital, what's the best way to, one, get informed about them and to participate?
So, I mean, there's different ways we would usually recruit patients for our studies. So it starts from our clinical practice and approaching patients as you see them in everyday clinics. Of course, we are open to a patient calling us to know more about the studies we are conducting and to which extent they can take part in the clinical trials. That can be made through contacting directly us. There's also other tools, for example, Fox Trial Finder, in which we always try, at least our investigator-initiated trials, to be advertised and listed in that site. There's also perhaps other more, perhaps less easily accessible, but there's, for example, clinicaltrials.gov, where any trial that is being conducted, at least in North America, needs to be registered there, and, for example, where the contacts also need to be listed. So there's different ways we can spread the word, and sometimes also there's advertisements of the trials in the hospital, although not less frequent, I should say.
Okay, that concludes our Q&A. How about one last round of applause?
So maybe I just wanted to put
You're never done with researchers, eh? He just needs to get one last word in.
So I wanted to highlight that, although we're sitting up here on the stage, that a key part of our team is sitting over in the corner. So Nereus and Shauna are research coordinators. Deanne is also a research coordinator for many of you in the audience. And then our two nurses who many of you really interact with a lot now. It's been a lot of time trying to help everyone, Darlene and Jeannie, who are, again, are key parts to our team. And we certainly owe a lot of thanks to them.
I think that was worth it, eh? You can interrupt anytime to thank your staff. So thank you to everybody for being with us tonight. As mentioned at the beginning, we'll have refreshments up outside of the amphitheater. Our panelists will be mingling about. If you have some questions for them, some follow-ups. Again, if you think of something later on, please don't hesitate to email us. We will happily forward your emails along and hopefully provide you answers to your questions. Thanks again. Thank you to those at home who tuned in, and we wish you all a wonderful evening. Merci et bonne soirée.